Hi everyone.
Uh, I opened the link. I'll leave from this laptop. So I'll make someone the co-host, the host.
Isha, you will share this thing screen.
I don't know why there are two Ishas.
I thought it was two devices. No,
No.
one of them became Sharon.
Ah, nice.
Isha, you will share the screen.
Yeah, of course.
Okay,
Works.
thank you.
Should we invite Smitha? She's speaking.
Okay.
Wait. I've only put Teresa's name on the slide. Do you want to invite Kate or someone else?
No, I think Kate replied saying she's glad Teresa is speaking on behalf. So it's only Kate, I think.
Only Teresa is speaking, right?
Only there is.
Okay.
I'll put a message in the waiting room that we'll start shortly.
Hi everyone.
Yes,
Smitha
Smitha.
here. Hi Sharon. Hi you.
Thank you for coming on short
Happy
notice.
New Year.
Happy New Year.
Happy New Year.
Not at all.
There are 4 people in the waiting room. Should we Kate, Ashutosh, Sunita, right?
I put a message saying we'll start shortly. Maybe we can wait for a few more minutes. Anything we need to discuss?
Should we let Sunita in? Oh, that's fine. Okay.
Yeah. Gauri also is trying to admit. So in the previous one, where do we think we took a longer time? The background took a long time, I thought.
Yeah, but I thought that it was good to have quotes and stuff.
Mhm.
Well, I thought my section also oddly longer than expected, but that's probably because I was speaking in Hindi also.
Mhm.
But yeah, this time Smitha and Momo will I will invite them to speak for reflections as CLG members, FIs.
Mhm.
And then later on, Sunita. Let's only keep Sunita and then we can open it up. I don't think Gauri said that they won't be able to speak, yeah? Isha?
Gauri's here.
Yeah, yeah.
So why not go? Is Aksa going to join us?
I haven't gotten a confirmation. Not
I
sure.
think I will speak, but I thought it will be really good if both of them or at least one of them can really comment for reflections.
Yeah, Aksa, I'm not clear if she will be able to attend. Gauri is traveling, so
Oh, okay. No problem.
Sharon, I open and then hand over to Anant, right?
yeah.
Okay.
Yeah, Smitha, I'll invite you first, so you can speak and exit the call whenever.
Okay, 7 p.m. I think the Hindi one we might have gone more than half an hour.
Yeah, so shall we admit? Yeah,
Yes.
admit all.
Hi, everyone. Hope you're all doing well. On behalf of Sangat and the I Hear Vaccine Security team, I would like to extend a warm welcome to everyone here. Today, we will be having the dissemination webinar in English for the I Hear Vaccine Equity 2 project. Earlier today, we had another one in Hindi. So I Hear Vaccine Equity 2 project was a 1.5 year long project that we just recently concluded. The project was looking at vaccine access among the transgender, intersex, and disability communities. Today, we'll hear from different people in the team, in the advisory board, people who are field investigators about the project, what we did, and what we learned. And together, we hope to figure out how we can move forward from here, use these findings to make our vaccination services more inclusive and equitable. Today's webinar will be 90 minutes long. It will be in English. You may feel free to keep your cameras on or off, depending on how you feel today. Please do keep your mic switched off unless you're speaking. You may add your names to the Zoom profile. If you click the three dots on your screen, the top right corner, you can do that. If you're comfortable, you may also add your pronouns and share with all of us. The presentation would include discussing sensitive aspects which may be triggering. If you feel triggered, please feel free to step out at any point and come back at any point without any worries. We would like to record the webinar, so after the slide, if everybody is okay with that, we would like to start recording this webinar. We are planning to put it up on our YouTube channel so that it will be available as a permanent resource for anyone who would like to watch it. In between the webinar, we would also like to take a picture of all of you together. If you would like to not have your picture shared on social media, you can directly message me. We will be having a short Q&A session towards the end, but if you have questions at any point of time, you can either raise your hand or put it in the chat. We will either try to answer it at that point or later during the Q&A session. So that's it. If you're all comfortable, make sure you're actually comfortable. Get a cup of water or tea, some pen to make notes and jot down questions if required, and then we will get started. All right. Oh, I see that we've already started recording. Just to give an overview of the structure of the webinar, since that might be helpful. After the initial welcome from me, and then I'll hand over to Anand, who will give a brief background of the project. Then Sharon from my team will speak about what we did in the project, the methods, all the steps that we followed. And then Isha will be speaking about what we learned from the survey primarily. And then Momo, who was a project consultant and an advisory board member, will speak about some of the challenges we had in the project. Then, depending on time, we'll take a short break. And then we'll come back to a more informal, unstructured part of the webinar where some of us will be sharing our reflections from how it was as a team member, as an advisory board member, as part of this project. And then we would like to hear from you questions, comments on what you feel based on what we shared, and then we will close. We will plan to finish by 90 minutes so that you may feel free to leave for anything else you might have planned after that. So you can definitely keep us accountable to that. All right. Okay, so for the first section, I will be doing that. I'll give a brief overview of Sangat and I here. Sangat is the organization that hosted this project. Sangat is a 28-year-old non-governmental, non-profit organization. We are one of the leading mental health research organizations in the country, for which we've been quite well recognized, including being awarded the WHO Public Health Champion Award. This particular project was hosted in the Sangat Bhopal hub. We were born in Goa. We have offices in Bhopal and Delhi and several other field offices. The Bhopal office of Sangat has been working in the state of Madhya Pradesh for the last 12 years, working in several projects, primarily mental health, in partnership with the state health department. We currently implement over 20 projects, a lot of it in mental health, digital mental health implementation side, but also in health equity, especially working with the transgender community, people with disabilities, and also some work on health research, ethics, and capacity building. We primarily work in 5 districts in MP. Now we've started in several more districts in MP. MP is Madhya Pradesh, as well as some of the adjacent states, and some projects have been taking a national landscape approach. Now coming to I HERE stands for the Initiative for Health Equity, Advocacy and Research. I HERE is a team that is hosted at Sangat, and our focus has been to work towards achieving health equity, especially for different marginalized communities. We've been primarily working with the LGBTQIA+ and the disability community. This work started because of some of our close colleagues, Dr. Aksa Sheikh and Dr. Satendra Singh. Dr. Aksa is a trans woman herself, and Dr. Satendra, a person with disability. And because of their own lived experience of facing challenges in accessing healthcare, was what that motivated us to start this work in the first place. Today, as co-leaders in I HERE, we work together through several projects to achieve health equity, some of which are participatory research, looking at the challenges in healthcare access, vaccine access, online gender-based violence, accessibility of hospitals, etc. Another vertical that we've been doing a lot of work in is looking at medical education, developing competencies on what a doctor needs to know to provide affirmative care, training a lot of doctors, especially medical educators, towards providing affirmative care, creating content that can be used in medical curricula towards teaching medical students and other health professionals to provide affirmative care. And then finally, a lot of work on capacity building, going beyond medical educators to train people from the communities, the LGBTQIA+ and disability community, to do research and advocacy towards achieving health equity for their own communities, training medical students to work towards making their own campus inclusive, training health research and health funding organizations to be more equitable and ethical. And a lot of this work has been focused on creating impact and change. And for that, some of the things that we've been actively doing is engaging communities in various forms. And Sharon will be speaking more about how we did that in this project, engaging with media, engaging with policymakers, and of course, academic engagement through publications in peer-reviewed journals and academic conferences. Through all this work, we hold certain values closely. One is equity, that equality is not enough when people are unequal. Second is intersectionality, that none of us hold just one identity, and depending on our context, multiple identities shape our experiences. Third is lived experience. We believe that people who've been through what they've gone through are the real experts. Lived experience is expertise. Fourth is that we work closely in partnership with communities in line with the phrase, nothing about us without us. Fifthly, we have been focusing towards creating high quality evidence, high quality research, but not stopping at academic publication, but working towards real change through advocacy and capacity strengthening. And all of this work has been possible because of several partners from India and abroad. A lot of it has been through competitive research funding, but also corporate social responsibility funding and international multilateral organizations. In India, we closely work with Sati, Kasturba Medical College Manipal, and University College of Medical Sciences, New Delhi. Now I'd like to invite my colleague and the PI of this project, Dr. Anand Ban, to speak about what was the background that led to this project, I Hear Vaccine Equity 2. To briefly introduce Anand, Anand is a medical doctor and a public health researcher with over 20 years of experience in the fields of global mental health, health policy, and bioethics. Over to you, Anand.
Thank you, Hari. Hi, everyone. Good evening, good morning, depending on where you're joining from. So in line with what Hari mentioned, we'll just quickly go through the background. I'll try to keep it short so that you can focus on the findings of the current study. But just by way of context, during COVID, we had initiated a study called Transcare COVID-19, which tried to understand the experiences of the transgender community with accessing healthcare during COVID-19. And during that project, which was a qualitative project, one issue which came through, especially as vaccines started to get introduced, were questions of access to vaccination. And that led us to apply through a competitive funding call to the Sabin Vaccine Institute for our first project, which was I Hear Vaccine Equity 1.0. Once that project ended, the findings from that have led us to the current project, which you will hear the findings of, which is I Hear Vaccine Equity 2.0. More on that coming up later in the webinar. So as you all know, decisions around vaccines are sometimes complex. They're not pretty straightforward. When people or communities decide to take vaccines or decide not to take vaccines, there might be multiple things which are going around in terms of predicting factors, in terms of reasons for feeling that they're comfortable with that decision or not, or wanting to delay a decision till they are comfortable with going ahead with vaccination. And that's what we've been trying to explore through these series of projects. And you'll hear again more insights from the communities that we work with. Next slide, please. So specifically in the first project, which was a qualitative participatory study, which we did from October 21 to February 23, we focused on trying to understand challenges in terms of vaccine access among two communities, which was the transgender and disability communities. And our findings indicated that there were indeed specific unique challenges which the community members who are kind enough to share their perspectives with us told us around specific health needs and information lack, their inaccessibility of vaccination, systemic mistrust and neglect being an area which was, again, predicting decisions around vaccination or about or whether to get vaccinated or not. And you will hear more about that also in some of our slides which speak to the findings. Next slide, please. So the kind of thematic areas which came was the first one being there was a sort of neglect of these communities. So we had, for example, some young people who had multiple comorbidities, including sometimes also having disability, and they were lost in the priority setting exercise. So as you know, in India, there was a whole priority, a set of priority populations, and young people were not part of that for perhaps for good reason, but then forgetting that a lot of these individuals with comorbidities who might be young also were at high risk of serious COVID-19 disease, as well as potentially mortality associated with that. And they were not part of the thinking around prioritization. And that was something which came through in some of our interviews as well. There was also the challenge of neglect at vaccination centers. And this was, of course, also influenced by their past experiences with trying to access services from the health system, which were often mired in not being made to feel welcome, not having accessible services available, and sometimes being shunned or discriminated or stigmatized against. Also, many of these communities did face a lot of social and economic changes because they are usually at the margins, might be dependent on daily wage earning, and that was, of course, impacted due to the kind of impact that the pandemic had, including lockdowns, etc. Next slide, please. So in addition to that, what we also found was the fact that many of these communities were searching for answers because the landscape was evolving very fast. Vaccines were coming through. but evidence was catching up slowly, or was sometimes not available, or was not available in adequate detail. For example, someone who might be transitioning, doing a gender transition, and might be taking hormones or might be taking therapy for that, they were unclear on trying to understand what would be the interaction of the vaccine with the therapy that I'm taking, and is it safe to take the vaccine? Should I delay the vaccination decision, etc.? And they could not find answers to these questions, even if they tried on publicly available government websites, etc. Sometimes they had to reach out to medical professionals in their trusted circle, might still not always have the answers. Persons with disabilities, similarly, who might have multiple chronic comorbidities, were also struggling with that question. Is it safe for me to take the vaccine? Can I take the vaccine if I have X comorbidity, etc.? And again, they might not always have answers, but sometimes they did find answers from a trusted circle of practitioners, of families, friends, and community members, which then helped them take a decision. Negotiating trust in the vaccine, as we know, any public health imperative and intervention, whether it is implemented and how it is accepted by communities, depends a lot on trust. And the fact that there is a historic mistrust of health systems given their negative experiences, that also, of course, then impacted their decisions around vaccination. And where there was strong trust existing, I think those decisions were easier. But where there was not that trust, or there was a deficit of trust, then that did impact decisions around vaccination in a more negative manner as well. And this speaks to the importance of trust building with communities so that they feel comfortable then also taking interventions which might be in their benefit, but where the historic marginalization impacts their perspective about these interventions. So that was theme 3. Theme 4 sort of speaks about the systemic nature of these issues, where people from these communities, when they were trying to access a vaccination slot, might find it difficult because the digital portals were sometimes not designed for persons with disability. Someone who might have a visual disability, for example, might struggle with being able to get a vaccination slot if there was a limited number of slots and you had to quickly go through the processes of trying to find a slot. There was a requirement for mandatory ID cards for some time, which might not always be available for someone who is who's a transgender person and is not comfortable with their ID, which is related to their birth name, etc. There was transport inaccessibility during timings such as the lockdown, which made it extremely difficult to get to a vaccination center. Even if you got to one, would it be a place which is accessible for someone with, for let's say, locomotor disability? There were initiatives around home vaccination, but that happened slightly later. During the early period, that was not an option. And also the fact that many of the individuals from these communities were also concerned about not being treated respectfully at vaccination centers, given their past experiences. And also when they went, sometimes they were not treated with respect or were again made to feel uncomfortable, which also impacted their decision. Next slide. So these were the kind of sort of key takeaways, and we also have some papers that we can share from our early findings. But largely, these indicate that there were a lot of pervasive and structural inequity issues which impacted decisions around vaccination. And COVID-19 vaccination is an important case study which can tell us more as we are discussing as a health system, and similarly to many other LMICs around more adult vaccinations. What kind of things can we do to ensure that communities, especially those which are marginalized, are able to access vaccination? Next slide, please. So again, as many of you know, WHO came out with a survey and a framework, which is the best framework and survey, which focuses on trying to understand how decisions around vaccination are taken, what drives people to take vaccines, and this data is then used to improve vaccination programs. And what we did is try to look at the framework and try to understand that, is this fit for purpose for marginalized communities like the communities that we have been working for, and realize that there were major gaps, which is where the idea of Vaccine Equity 2.0 came from. Next slide, please. And that's where we designed this project to specifically focus on looking at the best survey, but try to expand it or adapt it to measure behavioral, social, and structural drivers of adult vaccinations among transgender, intersex, and disability communities in India, to do field testing and analysis, to propose an expanded framework based on this initial work, so that the framework and the survey could then be a more well-adapted framework, which could be used to be more and also be more inclusive, and to also analyze these findings and be able to make policy recommendations, community-facing recommendations, some of which we will share today as well. Next slide, please. And so our project team brings in varied expertise, professional expertise in terms of their qualifications and areas of experience, but also importantly, lived experience. Many of us are also members of the communities that we work with and bring that strong lived experience to the work that we do and the way we conduct our studies. And that, I think, has been a huge learning for all of us, the importance to center stage lived experience in the work that we do. We have, of course, also been very much guided by a community advisory group, which we call the Community Leadership Group, which is drawn from community members, next slide please, who have worked with us all throughout the design phase of this study, the conduct, the initial data explorations, the data analysis, and the reporting stages, and given critical feedback to us to help us refine our approaches and the way we have thought about this study. And it is through their input, some of who, in many of them have joined today as well, and we are thankful to them for their contributions. And we also had a project advisory panel, which again has members who are drawn from the communities, as well as people who've been on the program side, and their inputs were very useful as well in terms of thinking through how we approach this project, as well as how we conduct the study and how do we develop our findings, etc. Next slide, please. So again, with all of those inputs, this has the project has now almost come to a close, and that's where we are today. Critical to this has been the support of our funder, the Sabin Vaccine Institute, who worked with us with Vaccine Equity 1.0 and then also supported us for Vaccine Equity 2.0. Teresa is here from the Sabin Vaccine Institute, and I would like to invite Teresa to speak a few words on behalf of the Sabin Vaccine Institute team about this larger initiative that they funded, one of which was our projects, and also their perspective around how this work might be relevant to the larger global health community. Hari, you had something to add before we end?
Yeah, one of the Smitha is here, and Smitha has to leave by 7. So I was wondering, Teresa, if it's okay if Smitha goes first before you.
Okay, sure. That's fine. Yeah. All right. So Smitha, if I could invite you to speak. Smitha is a member of our community advisory group, and Smitha is leading disability rights campaigner, activist, who's done some really innovative work around advocacy, and has been a long-term leader in this domain and a supporter of iHear and an active collaborator. Smitha, over to you.
Thank you so much, Dr. Bunn, and sorry that I had to hurry you guys. And it was a remarkable experience, and to be part of the journey. And I am really excited that this study, both 1.0 and 2.0, have come out very well with an in-depth participatory approach. So and it is not like something tokenistic, but I have felt the participatory approach at every stage. And myself, coming from the disability community and having worked with vaccine dissemination for persons with disabilities and advocating with the government on doorstep vaccination and also making the vaccination centers accessible, we have been facing a lot of challenges. And of course, we saw all those challenges in 1.0 study. And I really appreciate that I hear didn't stop with 1.0 and really took it forward, because challenges, of course, all people know, and we have also highlighted to the government. Whereas in 2.0, we have the clarity on the structural barriers, the practical issues, and there is also these deep-rooted inequities which have come up in the study. And this report will definitely guide the governments to ensure vaccine equity for different marginalized communities, whereas we see that there are a lot of issues even it can be, we don't see it as connected, like the transport or the caregiver, the support system, or the information being disseminated to people with disabilities and other marginalized communities on vaccination. So these are all around the core theme of vaccination, whereas it is it is really enlightening to see that these have contributed so much, for the inequities, and which the when the government reads the report and can act on this, it will be really awesome that the government, this report will definitely help the government to take the next step forward towards vaccine equity for all marginalized communities. And I appreciate the whole team for the entire excellent participatory approach at every stage, and for giving this such scientific and evidence-based document. Thank you so much.
For your kind words, and of course your contributions and that of the other members of the community leadership group has been hugely a part of what we've been able to do. Thanks for your comments, and thanks for joining us. All right, Teresa, over to you to again speak on behalf of Sabin Vaccine Institute and for also your own insights around this work.
Great. Thank you, Dr. Bond, and thank you everyone for inviting me to come and speak. I'm really excited to be here. So my name is Teresa Summers. I'm from the Sabin Vaccine Institute in the Vaccination Acceptance and Demand Initiative team. And our overall focus in our programs is to both understand the varying reasons why vaccines don't get into arms, and then understand and try to develop solutions to address those concerns, with a particular focus on community-based solutions. And so one of the ways that we, in our programs, that we do that is through our Social and Behavioral Research Grants program. So this is a program, excuse me, that's been going on since 2019. And the focus is really, we provide small grants to local community-based organizations and researchers to kind of understand the social and behavioral drivers of vaccine acceptance, vaccine hesitancy, vaccine uptake, and then identify and pilot solutions. And so since 2019, we have funded 25 teams across 15 countries. And this spans South Asia, Southeast Asia, Africa, Central America, Western Pacific, and so we've really expanded a global reach, and we've tried to do that. We've had the great fortune of working with, as Dr. Bond mentioned, working with the Sangath team for 2 cycles now, with the iHear 1.0 and now iHear 2.0. And I think that this project, I think, is really exemplifies what we hope to do with the Social and Behavioral Research Grants program, right? The focus on participatory methods, the focus on marginalized communities, where I think we're really, with this program, have been focused on understanding what we don't know, and what we don't know in marginalized areas, marginalized communities, and areas that typically maybe don't get a lot of notoriety or focus on them. And so we've worked in other parts of India with the Social and Behavioral Research Grants program. In other cycles, we've funded programs in New Delhi. We funded in the height of the COVID pandemic. We funded a study looking at COVID vaccine hesitancy in Bihar and Uttar Pradesh. So we've really tried to expand. We've had a lot of work in India as well. And so one of the ways that we try to amplify findings is part of our other program, which is the Vaccination Acceptance Research Network, which has been going on for the same amount of time. And this is a network of researchers, as well as policymakers, implementers, people who work in multilaterals. We have a pretty diverse group of members in the VARN network. We've held 2 conferences. The first was virtual, and the second was a year and a half ago in Thailand, and we had we had some of the members of Sangath present their I Hear 1.0 at that conference, as well as some of our other grantees. And then we have recently moved that network fully online and to make an online community. And so through the VARN network and through some other work that Sabin does more broadly, our idea is to really take all of these kind of the findings and lessons learned from these community-based projects that are focused on different marginalized communities, and to really amplify those findings up so that they can influence policy, programs, practice at all levels is really our goal. And so I'm really excited to be here and thank you again for inviting me, and I'm really excited to hear more about I Hear 2.0. So thanks so much.
Thanks a lot, Teresa. It's been an absolute pleasure working with the Sabin Institute, right from Vaccine Equity 1.0, 2.0. And, unlike many other conventional funders, Sabin has also helped connect us when we needed inputs, make the connect with WHO easier because we wanted to have that conversation in the formative part of this project, etc., and has been a huge supporter of the work and the importance, and sort of again highlighting the importance of trying to understand perspectives of communities. I'd also like to acknowledge Kate, who's also here from the team. Thanks, Kate, for joining us as well. All right, so I think now what we'll do is get to the fun part, which is the findings. Hi, Kate. And to do that, I'll invite Sharon. Sharon is a psychologist and rights-focused researcher who's been with us right from the 2 projects and has been a key member of the research team who's been leading a lot of this work. And Sharon, we are excited to hear from you what we've found in Vaccine Equity 2.0. Over to you.
Thank you, Anant. So just to bring back to the project, what we discussed was that we were trying to expand the BESDA survey to develop a survey that taps into the needs of the intersex, transgender, diverse, and disability communities. And we were also trying to not just develop the survey, but also report on the factors that we identified in the survey. So those were the 2 aims. And in order to sort of achieve those aims, we approached a series of methods. We can go to the next slide. The first thing that worked through was intertwined throughout the lifespan of the project was the participatory approach. And in simple words, it's making sure that community members are involved within the research process throughout the research process. And not just in like a consultative role, but as people who are doing the research, as people who are decision makers in the research process. It's an approach to power sharing within research, which is, has a historical background of not being equitable. So it's an approach to reduce harm within research, the research enterprise. So a few ways in which we approach this was one, like Anant already shared, a lot of the researchers are from the communities that we are trying to work with. Then we also had the community leadership group. Smitha is a part of it, and she was able to share some of that. And we spoke to the community leadership group at every instance. So once when we were finalizing the research design, when we were trying to develop the tools for the research, for recruitment, for how to disseminate the findings. Also, recently we met with them to discuss all of that. And lastly, we consulted members of the community at particular stages. So one example of this is when we wanted to figure out, we want towards stakeholder analysis, what questions are the most important to ask in this survey. We went back to certain community members and consulted them for the same purpose. We can go to the next slide. Now I'll just quickly take you through the flow of the process, and then we can reach the findings which we've been waiting for. So the first step is the item generation stage. This process is trying to identify what is the universe of questions that we can possibly ask, that is trying to assess the behavioral and social drivers of vaccination within these 3 communities. So in order to do this, we had 4 sources of data. One was the Vaccine Equity 1 study. We reanalyzed the data from that particularly to identify those factors. Second, since the first study didn't involve the intersex community, we conducted interviews with the intersex community. Third was we conducted 5 interviews with vaccine program managers so as to also look at how the survey might be from the perception of people who might have to use it. So program managers, people who've worked in the vaccination space for a long time. So their feedback on what the survey should look like was also very valuable. And finally, we did a literature review to look at other studies in the global south that have also looked at vaccination access within these 3 communities, and we teased out factors from there as well. And ultimately, we had 62 factors and questions. So once we had these 62, 66 questions, we had to decide how we can reduce that number. So that exercise was called a stakeholder review that was trying to rank the importance of each question. And so we came down to 52 questions after that. So we had 18 stakeholders, and they were from the 3 communities and also some vaccine program managers. And they ranked each question from 1 to 5, which was from not at all important to extremely important. Each question, if it had 80% or more of an agreement on the question that it is important, that's when the question we would finalize. If not, then we would discard that. Some questions did not meet the criteria, but we went back to the drawing board, discussed the question if it felt important, and through internal discussions we came down to 52. The next step was language and cultural adaptation. So the survey was in 2 languages. English, we developed it in English, and it was also in Hindi. We followed the ISPO guidelines for language and cultural adaptations. And it's a long drawn process where you translate from English to Hindi and then Hindi to English, and then compare the different versions of the translations to see what is the difference, and try to make sure that it's reconciled across all versions. In addition to that, we do something called cognitive interviews, where we're trying to understand, now we have a survey and we have all of these questions, but are the way that we phrase the questions, is it communicating what we want it to communicate? So we'll ask a question and then we'll ask them, what did you understand and how would you answer this? How are you thinking about this question? So that's what a cognitive interview is, and it helps us fine tune the language and the structure of the survey. Finally, the field testing phase was where we took these surveys, we uploaded them on RedCap, which is a platform like Google Forms. And we conducted the survey with 236 people from across the communities, mostly the disability and trans community. We'll discuss about the limitations going forward. And we were able to do this primarily with the help of field investigators and the research team. We conducted a series of training sessions with field investigators from these communities only, where we would talk to them about the survey and what interview methods they can use to talk to people, recording, consent, etc., etc. So those field researchers went out and also conducted the survey, and they were the reason why the numbers are as high as they are. And finally, we had 2 ways of sort of analyzing the data. One was to validate the survey, which Isha will share a little bit more about later, and then the descriptive statistics, which is basically what percentage of people responded XYZ to a particular question. So that was the process flow. And now I'll invite Isha to talk about the results. Isha is also a psychologist and an assistant research coordinator at iHear, and they started working with this project, and I'm really happy to invite them. Yeah.
Thank you, Sharon. As Sharon is seeing in the analysis, we majorly like took 2 different ways. One was looking at a descriptive part, where we looked at the percent distribution over certain responses, and then we looked at some polyphoric correlations to see if there were any items that were strongly correlated with outcomes such as intention to get vaccinated or the duration of getting vaccinated, etc., or the accessibility. And second part was to validate a tool. So looking at the internal consistency, the factor structures that are emerging out of the survey, etc. So let's look at a descriptive part. Like before going to descriptive part, let's look at the demographics very briefly. So we mostly focused on transgender, disability, intersex community, and in the transgender community, we were able to reach out to trans men, trans femme, non-binary, gender fluid persons, Hijra, Aramnik in the communities, etc. Under disability community, we were able to reach out to people with locomotor disabilities, people with visual disabilities, hearing disabilities, blood disorders, etc. In terms of location, most of the surveys are conducted in Madhya Pradesh, Maharashtra, Delhi, and Uttar Pradesh, and a small number of surveys was conducted outside of those 4 states. We were able to look at both urban and rural communities. So yeah. In terms of descriptive output, like analysis, like numbers that we got, some of the major findings were as follows. So nearly 55% of the specifically in context of trans community, nearly 55% participants, they talked about having encountered some sort of prior experience of stigma in healthcare setup, and nearly 69% participants shared that they feared or they anticipated stigma in healthcare settings, which was sort of related to the hesitancy of getting vaccinated. In terms of trust in healthcare systems or healthcare workers, 52% participants and 42% participants respected trusted healthcare systems and healthcare workers respectively. So it was slightly higher with healthcare systems here compared to healthcare workers. Then we looked at what were the attitudes towards vaccine and how it, what was the vaccine uptake. Nearly 70%, 70% participants, they showed desire to get vaccinated, like there was strong willingness to get vaccinated among TGT community. Then again, 71% participants were confident that getting vaccinated would actually contribute to was safe for them to get away from stay away from COVID. As you can see, nearly 81% participants had gotten vaccinated within 6 months after the vaccination was made available to the other communities. However, only 41% participants were confident that the vaccine was compatible with their specific needs or with their specific regimen with respect to the procedures that they were going through or the medications that they were on, etc. When we were in terms of the vaccine, barriers to accessing vaccination, 3 major factors that came up along with other factors, but these were the main factors. Was having to wait long times to get vaccinated, so long waiting queues, or as was also seen in previous studies, there were instances where where participants were asked to come at a different time, come earlier or later than the other people, or they were asked to go back and then come back when there were certain doctors present at the center. So this was similar to that. Secondly, having gender discordant IDs. So if, for example, if the ID was registered in the participant's dead name and their present name, if they were not matching, that the chosen name and the dead name was not matching, then that led to some barriers to get vaccinated. So that was something that 57 participants had reported. And nearly 54% participants had talked about having to leave their work duties. So it was difficult for them to take a leave or not be working. Some of them were daily wage workers. Some of them it was difficult for them to not to leave work and then to get take that day to get vaccinated. So there was, as you can see, there was strong willingness, but there were some logistical barriers that while looking at disability community, we saw that there was higher trust with healthcare workers compared to healthcare systems. Nearly 48% population participants showed really high trust with health workers, whereas 39% participants talked about had moderate to low trust on the health systems. While looking at what were the motivators for them to get vaccinated, two factors that majorly came up were to be able to access public spaces like parks, theaters, and from two aspects. One was having the access to use those places, and second was to be responsibly present there without harming anyone. And second was the belief that taking the vaccine was good for their personal health, or it would keep them safe from from the COVID-19. 59% participants reported that there was low accessibility of information. So if they wanted information regarding the specific about the vaccine in context of their specific needs of their disability, so it could be under the medication, or if their disability or would somehow hinder access to vaccine, there was no information available that was contextualized for them, that was specific to what they required, and it was very difficult to track that information down. So nearly 60% participants reported that, and 26% participants talked about having low accessibility at vaccination centers. In terms of barriers, nearly half of the participants they talked about not having lack of escorts as something that really hindered their access to vaccine. Secondly, having information that was accessible to their needs. So the information, for example, in audio format or in braille, or in formats that they can easily use, was something that was a major barrier. And near 34% participants had talked about affordability. So not affordability, not just from the context of paying for the vaccine, but also in terms of having an accessible mode of transportation to the vaccination center, from vaccination center to home, then working with escorts who can help you around with vaccination, then also having to take a day off from work, or if that is having some financial implications, that also came into the factor of affordability. So yeah. Within disability community, we also saw that the service satisfaction for vaccination services was nearly 66%. They reported lower, lesser participants reported having to wait in longer lines. And nearly 70% participants they talked about having some sort of medical support post-vaccination, which included either medication or counseling at the vaccination center. And 74% participants had talked about having adequate staff training. So staff was able to give them enough time. Staff was able to address some of their questions and talk to them respectfully, etc. In correlations, we saw that having the medical support was a key factor. It was significantly correlated to ease of access. So secondly, information clarity was also highly correlated to accessibility, which was also a similar case for disability community, where medical support showed a positive correlation with ease of access, and information also showed. Yeah, so this was something that brought it to communities. That was similar in both the communities. In terms of policy recommendations, creating all gender or like gender specific affirmative toilets to ensure privacy and comfort is something that would be like a very supportive initiative. Then training healthcare staff to offer more time to have adequate support for trans community, to use inclusive and non-discriminatory language, to have spaces where healthcare settings within healthcare settings that can reduce stigma, that are aware of the contextual and like the specific needs of trans community, would be very beneficial to increase vaccine access or vaccine desire to get vaccinated as well. Also, working with gender discordant IDs without judgment, or having some sort of space there where would also be very beneficial, specifically in context of trans community. In terms of disability community, having inclusive and accessible information that caters to the needs of persons with different disabilities would be very beneficial. Then safety information for individuals with disabilities, like so about vaccine safety, about addressing concerns of unique to their disabilities, would also be a key factor for vaccine access. Thirdly, accessing healthcare, like having accessible healthcare centers which have like ramps, elevators, accessible washrooms, disability staff that is aware about disabilities or how to work around that, would also lead to higher vaccine, vaccine acceptance. And implementing disability-friendly systems for appointment bookings or for ID verifications or for vaccination scheduling could also be a key factor. And lastly, designing flexible healthcare programs that include caregiver assistance or home-based vaccination services for individuals with severe disabilities who would be more comfortable with a home-based vaccination with escorts, etc. would also thought be helpful. So thank you for listening to me ramble for almost so long. Next, we would like to talk about the challenges that we faced during this project. So I would like to invite Momo to discuss the challenges. So Momo is a molecular biologist. They also work with intersex rights, and they've been working as consultant for vaccine equity too, as well as they're also a part of the CLG team, and they helped us with a lot of insight and like outreach at like multiple stages during the research. So yeah, Momo, over to you.
Thank you so much, Isha. Hello, everyone. I hope you're all doing okay. So, can we get the next slide, please? All right. So, we had some challenges within engaging the intersex community with recruitment and outreach. And despite having access to a sizable population of intersex individuals, actually reaching out to them proved quite challenging. The known population was not very approachable due to various systematic and interpersonal barriers. And a major challenge actually in this was the language itself, the language and the knowledge barriers that we sort of had to face, which created difficulties in establishing very, so I could say, clear communication with community members. A lot of our community members that we were reaching out to spoke a particular South Indian language called Tamil, and due to which non-Tamil speakers and a couple of us that were not Tamil speakers. So we had a lot of difficulty in reaching out to that sizable Tamil speaking intersex population and get to know their experiences on vaccine uptake and intake within their communities. There was also this fear of being judged, or rather the aspect that a person is not vaccinated or is in fact an anti-vaxxer themselves. And the fear was that we as researchers will judge them for not being vaccinated, or their data of being not vaccinated would sort of get leaked out in a public system, and then the community would know about them. So these barriers, these initial barriers did not just show us that, did not just slow the recruitment efforts for intersex community, but it also kind of impacted the trust building process for other intersex folks, which is very critical when we engage marginalized populations across India. There was, as I mentioned, there was concerns about safety and the judgment, but there was also this learning that we got at having community consultants and trust building is very important in research. And the theoretical assumption that we have sometimes that when you have a community member as a consultant, it would foster trust and streamline the recruitment process. But that does not always yield desired results. That was a learning for me. And while I saw that having community consultants can really bridge gaps and bring in a fresh, nuanced perspective. But it kind of also highlighted something that was that it does not mean that one size fits all forms of solution. And sometimes the dynamics within the community itself can create additional complexities, such as mistrust or internal divisions, and which kind of is a learning from the way forward is that we have to have we have to have an importance of emphasizing on diversifying the way we communicate with different community members, and the strategies that we should equip ourselves with, working with different community leaders and multiple community leaders out there, so that there is inclusivity and effectiveness in all fronts. The final point that I would like to end with saying that the limited role social media actually played in recruitment. Now, when we think of social media, we think it's often a very powerful tool for outreach and engagement. But in this specific case, it played a very limited role, and this was rather a learning as well. Many potential participants that we tried reaching out to were either not active on social media platforms or did not feel comfortable engaging through such channels. So this also tells us that how we assume working in grassroots levels, and emphasizing that social media can solve a lot of amplification and outreach work for us. So that's not really the case, but these were some of our learnings that we picked up from this project and research. Isha, over to you. Thank you.
Thanks. Thanks, Momo. I think we can, if everyone's comfortable, we can just try to take a picture, if that's okay. And yeah, then we can, I think, halt for a 5-minute break. Come back. Yeah, right. 7:35. Is that okay? Sorry. So should I? Is that okay? Cool. So see, to one smile. There you go. Yes. Again, everyone smile. 1, 2, 3. There you go. Yes. Thank you, everyone.
Hi, everyone. Good evening, and warm greetings wherever you are, and Happy New Year. I hope the year really unfolds better for everyone, given the global scenario with sort of wars everywhere. So I'm here really not going to spend too much time, but some of the sort of my own reflections, and a lot to do with the what is happening at the macro level, at the global level, and connecting the dots in terms of the what we have done across the two projects on the vaccine equity. But I also would like to really start with 3 observations here, and they are relatable to you just because I also draw them
upon the presentation right now that we've sort of, heard the team members doing it for us. So one is, that it's been highlighted, but I just want to sort of really mention and restate these 3 points. One is that this is the group and the organization, particularly the I hear umbrella at Sangat. All the projects, if you really sort of, try to recollect the first couple of slides where all the projects were enlisted, there's a very, very close organic relationship and the linkages across the project. So basically, sort of, every subsequent project and the initiative and the work that has been developed has been informed by the previous projects, initiatives, and basically the deeper insights into the issue and sort of, really try to build on that. I think to me, it is really, really important that, it's not, I know there are colleagues from Sabine here, but it's very important for the organization if you want to kind of, pursue particular area of work and with a sort of, sense of commitment to the cause. And here the two communities that have sort of, been central to all the work that at Sangat, especially I hear, so that organic linkages and not really sort of, really averting and avoiding falling into the sort of, falling into the funder driven agenda. Sometimes it really works, and that's how I mentioned it sort of, please, there's nothing about Sabin, but my point is, the organic linkages that have been built, it's a strength of this group. So that's one. The second is all of you might have been noticing, especially the members of the advisory board and the CLG, the members of the CLG. There have been immense effort that have gone into ensuring that the team also is sort of, makes reflects the commitment to the cause in terms of the representation that comes from the two communities. And it is hard to sustain these kind of teams in varieties of ways, and there are more than one reason why it can be challenging, and it has been probably, but we've been able to sustain these teams, and all the credit goes to the team. It's the core team, and I'm just a collaborator, basically, sort of, weekly meetings is what we interact, but the hard work and the core work really goes into the project, and the success is by the team members. So that's my second point, just to restate that. The third point is I'm always very happy to listen to the presentation and the reflections of the team when it comes to challenges. And that's a huge strength once again. And I appreciate that, because that's a learning, and it's very important that we don't really always get sucked into the successful stories, but always be mindful of the challenges. So for me, all these 3 points are really important. And I just want to spend another half a minute on the one of the challenges that Momo mentioned was that there's me and Anant, we have worked and spent a lot of our sort of, our research efforts over the last about a decade or more on community engagement. And we've been sort of, actually have worked on the conceptual understanding in different parts of the world. So it is very important also to understand the point that he highlighted is the dynamics within the communities, so not glorifying, not really taking it for granted that if we have team representation, the community representation in the form of these groups or the representation in the team itself, it doesn't necessarily guarantee that, that everything will go very well. So I think these kind of due diligence and the cognizance of the fact that there would be challenges, and no community is monolith. So that's the kind of, very foundational to understand when we use CBPR and these kind of, methods. My fourth point is, and then I'm going to spend another 2 minutes talking about some of the sort of, international level slogans and what it means operationally to us in that sense. So the fourth point I wanted to highlight is that, well, I forgot now. I'll come back to that. So let me switch to the some of the important kind of, I would say the spirited slogans, and they mostly come, all of us know they come from WHO or from the sort of, UN and some of those kind of international bodies. And many a times they might really sound like cliche. And I'm going to say a few things here, few of those. One is that, leave no one behind. The other one is, nothing without us, for us. There's something that we've been like, I've been in this space for last about 35 years, and we've been talking about inclusive care, patient-centered care, or patients, or the sort of, the research participant-centered research, because we're talking about the research. And I think it's sometimes they become cliche, as I said earlier. But I think some of these works that has been developed at iHear, and especially because I was associated with iHear Vaccine Equity 1 and 2, it is something that, how one can, the two levels of understanding that. One is, taking those slogans and the spirit of that, and how do we kind of, translate that into our research work, both in terms of the outcomes of those researches, and as we heard Sharon describing the methods and the very meticulous, nuanced processes that have been put in place to kind of, optimize on the participation of the communities, their representation, really sort of, trying to get their views integrated into the entire lifespan of the project. I think that's really challenging. I've been in research space, but I've never done CBPR. We've been only teaching CBPR. We sort of, conceptually we know what it is, but in my own work, I don't think we have done the kind of CBPR that we've tried to do in these two projects. And so I think it's, I said, as in terms of the processes, the methodologies that have been evolved. And I do hope that the core team sometime sort of, carves out some kind of a space and the time and the mental bandwidth to really document the methodologies, because that's going to be another very important contribution to the scholarship, working with the marginalized communities, particularly these two communities, and sort of, the strengths and the challenges of the methodologies that have been employed across the projects, but particularly these two projects, that's just because I know them better than the other projects under this umbrella. So one is the sort of, really upholding research participants' rights, dignity in meaningful way. And that's what we attempted to do. And as I said, the core team sort of, has done all of that work. And the second is, the outcome of these kind of research projects using those kind of methodologies. It's really important because it has that strength. Rigor is always there, but the strength is really important to appreciate the outcomes of these projects using these kind of participatory methodologies. And I think to me, these are some of the very important features of both these projects, and the kind of amount of diligence, commitment, the learning capacity. I think one is that they all come with masters and lots of kind of they belong to sort of different statured universities, but coming and doing CBPR based, using CBPR in one's own work is definitely challenging, and a lot of learning. I think one's attitude needs to be learning newer things and exploring ideas. So that's something is also a strength. So I don't want to sound like appreciating the team, but these are some of the realities of how we have worked, and the core team has been working on the ground. And the last point I wanted to mention that, the in-team kind of conversation and the ongoing deliberation, that also made a lot of difference to the quality of research that has taken place in these two projects. And as I said earlier, all of this needs to be documented, and how that really impacts the outcome of these kind of research initiatives, and it needs to be viewed with that lens, the methodologies that have been used, the participatory approaches that have been used, the limitations that have been sort of, spelled out, and they're out in the public domain. And then how do we see these kind of outcomes of these studies? Going forward, I think sort of, I would like to see that more and more of these work really sort of, informs policies, policies and sort of, programs in the coming time. And the team is already closely interacting with those spaces over time, and there's a sustained efforts to do that. So that's one sort of, it's also a complementary thing that sort of many of the NGOs and in this sector, especially in India, there's always a good component of advocacy, which is sort of, also has been maintained in this both these projects, and innovative methodologies, and sort of, I don't think we had enough time, but many of you who have been associated also with the earlier project, conceptualizing and implementing the photo voice stories as a method. I think that was also kind of a huge learning, but also very challenging method
Sorry,
to
Sunita.
on the ground. So yeah, so these are my
Sunita,
reflections.
if you can close in a minute.
Yeah, and yeah, I'm just closing. So kudos to the team in that sense. And as I said, learning about challenges is also something, a very honest, transparent kind of, putting it out in these kind of dissemination meetings. Thank you, and back to the team.
Thank you, Sunita. That was really insightful. In interest of time, I think I'll hand over to Sharon for the question and answer session. That's okay. Before that, Ashutosh, you had raised your hand, so I just wanted to know if you wanted to add anything.
I have just one comment. If you will do any project in future and you want any help from persons with the visual impairment side, please let me know and contact.
Okay. Thanks, Ashutosh.
Thank you
Yeah.
so much, Ashutosh. All right. For time, we can move to the Q&A section. I'll just go through the chat. All right. Yeah, Kate has a question. While there are unique findings between vaccine 1 and vaccine 2, there are also repeat findings in 2.0. I'm wondering if your team has found a positive change regarding those repeat findings or an appetite for policy, immunization process, and optimization. Yeah, I think just by way of the fact that some of the items in the survey are derived from the previous study as well. There are definitely, like, I think, a repetition of findings. It's just a sort of a, it's ultimately like a mixed method thing. We have the verbatims, we have the excerpts, and now we have the some sort of statistics as well. So I think it is more complementary than it is strictly unique. And yeah, I think in terms of the findings, that's what I would say. In terms of positive changes regarding those findings, I think so in terms of vaccines, I think if Hari, Anant, you want to come in, but a lot of the camps for HPV vaccines, etc., are community specific, are being conducted by community-based organizations, so that the design is inclusive and it's for the people from the queer community can identify that these spaces are affirmative. In terms of policy appetite, I would Anant, Hari, would you like to speak on that?
Yeah, thanks, Shannon. So, my sense is yes, there is more appetite, certainly. Perhaps the learning from COVID and some of the discussions around it, because while the COVID vaccination story was celebrated, especially in countries like India, which had fairly high vaccination rates, one of probably the largest vaccination program in the world, there was also a recognition that we could have done better, and some of the findings from this team, but also multiple other community-based organizations, point towards that. As health systems like India's now think about introducing more adult vaccines, I think some of these issues will also become relevant because, for example, disability is also something which would be relevant to an elderly population. So if India or other LMICs were to think of an adult vaccination program, which let's say focuses on flu, then how do you ensure that it is done in a way that communities which also involve a lot of elderly populations with comorbidities, with disabilities are addressed or are reached out to? So wherever we have talked to policymakers or to program managers, I think they've acknowledged that there are things which can be improved. And we saw that happen during the COVID vaccination period as well, that towards the latter part of the program, there were specific modifications made to accommodate for needs of communities. But of course, there is still a lot of work which needs to be done. And most importantly, I think having a health system which is inclusive, accessible, and affirmative, and that goes beyond vaccination, because vaccination is a health system intervention. But the larger question is, how do we make the health system by itself more responsive? And as a part of that, then any intervention, including vaccination, would also by design be responsive and inclusive. Hari, do you have any thoughts to add?
Yeah, thanks, Anand. I think definitely there is an appetite, and actually we've been in conversation with the UNDP since they've been actively involved in the vaccination program in India, especially adult vaccination. So in the context of emerging adult vaccines, we've been thinking about doing work together to actually facilitate this process of helping the government in setting up policies and frameworks to make these adult vaccine services more equitable. And we've actually we've been in the process of looking for funding together to facilitate that. So it would be something like a systems approach, but using participatory approaches as well, so that communities, community-based organizations, vaccine program managers, and multilateral agencies come together to think through these findings from this project, other similar projects, and then create a way forward. So that's something we definitely looking to do. Back to you, Sharon.
Yeah. Thank you for your question, Kate. Yeah, even just in the frame of the COVID-19 thing, there were, sort of like Anand said, a lot of provisions that were made for persons with disability. Not a lot, but like a few provisions that were made for persons with disability and the trans community. And there were guidelines that were released, but it was sort of towards the end of, say, one round of vaccination. So it was not something that they considered initially. So even just in the span of the pandemic, I think they took into consideration some of these aspects of equity. So I would also say that there is like a lot of possibility to engage on this subject. Are there any other questions? All right. A one, a two, a three. Okay, I'll give it to Hari to close. Yeah, thank you so much.
Thank you, Sharon, and thank you everyone for joining. I'll just take the next 3 minutes to thank the different people who came together to make this project a possibility. Firstly, thank you to the Sabin Vaccine Institute for this program and for this funding that has been provided. Then the study team, in alphabetical order, Ameya, Anand, Aksa, Bhakti, Chaitanya, Isha, Gauri, myself, Momo, Namdev, Pabitro, Satyendra, Sharon, and Sunita. The community leadership group, Anand, Abha, Chand, Daniela, Momo again, Jamal, Ritu, Shakti, Shampa, and Smitha. the advisory board, Professor Acharya, Shamala, Dr. Ramakrishnan, Dr. Raj Ghosh, and Haley McGregor. The enumerators who've been actively involved, especially I'd like to name a few of them who were particularly very active: Ashish, Anand, Kapil, Mohammed Faisal, Natasha, Nikunj, Rashid, Reyansh, and Sagar. And most of all, I think we are deeply indebted to the participants who've given us their time and shared from their own lived experience. Altogether, I think across the survey and the other components of the project, we engaged with around 270 participants. We're deeply indebted to them. Thank you so much, everyone, for joining us today. If you have any further comments or thoughts, please feel free to reach out to us by email, or if you have our contact details, please do that. Thank you so much for your time and have a wonderful evening. Goodbye.
Thank you. Bye.
Thank you. Bye-bye.